I'm going to be talking to you about hereditary antithrombin deficiency as an illustration of sort of the prototype for inherited thrombophilias. Okay, so for the next slide, just a brief show of my disclosures. Okay, and on to a little bit about antithrombin and what it does in the body. As you probably already know, antithrombin, as its name suggests, is an inactivator. It's a neutralizer of activity of not only thrombin, but other serine protease clotting factors, including factor 10A, and some others earlier on in the coagulation cascade. And it's also necessary for the anticoagulant effects of heparin. I'll come back to this concept a couple of times. But if we look at what antithrombin does by itself, it's really designed at baseline in a healthy person to keep the patient from clotting excessively. But when heparin is added, the activity of antithrombin is accelerated over 1,000-fold. So that combination or that mechanism is exploited very effectively with how heparin interacts with antithrombin. And no talk about coagulation and anticoagulation is complete without one of these coagulation cascade pictures, so I'm doing my duty to show it to you, but pay attention to the red X's, and those are the sites in the pathway that antithrombin exerts its effect. It's a dose-response effect, so to speak. So the less antithrombin a person has, the more thrombin generation would occur in a given circumstance, right? So this is an in vitro experiment by Ken Tanaka, where he diluted out a sample of antithrombin and showed that at each increment of dilution, the thrombin generation increased. So you can imagine that in a clinical scenario in folks that are deficient in antithrombin, that their thrombin generation and thrombin potential is going to be much higher, translating to mean they're going to be more likely to develop a clot. This slide shows you a very intriguing aspect of antithrombin that we don't necessarily, I think, fully appreciate at this point in time. And that is the so-called sort of other or pleiotropic effects of antithrombin. We know that it has coagulation-dependent effects of thrombin inhibition and inhibition of other serine proteases. But what are the secondary effects of those effects? For example, in thrombin inhibition, that leads to activation or prevention of activation of platelets and endothelial cells, and it suppresses factors that promote the neutrophil endothelial cell interactions. Inhibiting factor 10A activity, suppresses the neutrophil endothelial cell interactions as well, and its inhibition of activated factor 7 prevents complex formation with tissue factor and subsequent upregulation of cytokines, the pro-inflammatory cytokines. But antithrombin also appears to have coagulation-independent effects. So ones, in experiments that have sort of eliminated the coagulation-dependent effect, there's still suppression of platelet activity by increased prostacyclin synthesis. There's inhibition of attachment of neutrophils to endothelial cells, and just the release of pro-inflammatory cytokines is also decreased. As well, there's some direct activity that prevents neutrophil rolling and adhesion and subsequent tissue damage. So there appears to be, if you add all these together, a relative anti-inflammatory effect of antithrombin in normal physiology of the molecule. As I alluded to earlier, the effects of heparin rely on its interaction with antithrombin. I mentioned the anticoagulation effect of antithrombin is accelerated greater than 1,000-fold when heparin is given, and that's largely due to what the shape of antithrombin becomes when heparin binds, and it makes the affinity then and the activity of antithrombin against factor 10A especially and thrombin much greater. So there's a little graphic depiction of that. Okay, so as I start steering toward what happens in the body when antithrombin is deficient, you can imagine that the less antithrombin you have, the more prolonged circulation of activated procoagulant proteins you're going to have. And they'll circulate longer and thus increasing the risk for thrombosis. And as we see in some clinical studies, as antithrombin effect or concentration decreases, the VTE risk increases. And just for the purposes of categorizing deficiency, in most laboratories, normal amounts of antithrombin in the plasma as it's measured are usually at least 80 to 120%, and each percent is a unit per mil, and mild deficiency is designated as 70 to 80%, and overt deficiency less than 70%. So typically the heterozygous deficient patients have less than 70% antithrombin activity. So this was a very intriguing and very important study done in Italy by Bucchiarelli and colleagues that showed in a population this gradation. Was the lower the antithrombin activity, the higher the odds ratio for having a thrombotic event. Obviously, in this range of 45 to 60%, you figure that those patients either have a profound acquired deficiency or a true inherited heterozygous condition. And you would imagine that their odds ratio for having a clot as it stands, or even in the adjusted sense. But what was even more intriguing was that even mild deficiencies in this study population were associated with substantial increased odds ratios for having a venous thromboembolic events. So to me, in the clinical real world, in the trenches, when we receive results on antithrombin testing and they're only mildly low, we don't ignore those. We typically certainly corroborate that with repeat testing, but we don't just think that, oh, if you're just a few percentage points below the lower limit of the normal range of the laboratory, that it's nothing to worry about. We don't think that way. Just a reminder that pregnancy is a prothrombotic state, and this wasn't until relatively recently that Andy James from Duke reported the antithrombin activity decrease right in the peri and postpartum period, that then relatively rapidly returns to normal. So as you can imagine, that whole process of labor, parturition, that all stimulates and activates many aspects of the primary and secondary hemostatic mechanism, and certainly can affect in at least direct ways, maybe some indirect ways as well, the antithrombin activity. And I'll show you some clinical correlate that is related to this in the next couple of slides. So this was a very nice study by John Haidt. This is a population that's really taken from the general population. These aren't antithrombin deficient women per se, but it just highlights the skyrocketing of VTE risk in the first postpartum week, especially in the first day or two postpartum, that then gradually returns to baseline. Now, up until very recently, we thought that after 6 weeks, the risk of VTE in the postpartum period was really at baseline, which steered management recommendations for postpartum anticoagulation. But a very nice study recently published by Camelin Group in the New England Journal showed that risk really doesn't return back to baseline until after 12 weeks. So in our practice, actually, that made us modify and really select out patients that we thought during the second 6 weeks of the postpartum period, week 6 to 12 or 7 to 12, that some of those women were really at significantly higher risk for VTE, especially if they had a previous event. And many of them remain on anticoagulation for 6 additional weeks until week 12, because it's pretty clear that at week 12 in this study population anyways, the risk was back to baseline. So more specifically about hereditary antithrombin deficiency, we all know that it's an autosomal dominantly inherited disorder. Okay, so it tends not to skip generations. And honestly, I don't think we have a really good handle on the prevalence. Like how many people are really walking around with hereditary antithrombin deficiency? Obviously, there's a wide range that's listed in this bullet point of 64,000 to 640,000 people in the US. I think part of that range is due to the type of populations that are studied in the surveys that come up with these numbers. So I tend to think that if we look at selected populations, it tends to be a little more common. We look at unselected populations, it tends to be less common. But 64,000 people in the country is not trivial. Just as an aside, I take care of people with inherited bleeding disorders like hemophilia, for example. And in the country, there are probably around 20,000 people with hemophilia. So this, at the very least, is 3 times that number. When we look at a very interesting selected population, that is in hospitalized patients with VTE, the likelihood of hereditary antithrombin deficiency bumps to 3%, or 1 in 33, which is different than 1 in 500 to 1 in 5,000 when we think about the prevalence. And a high percentage, 5.4% of women with thromboses during pregnancy have hereditary antithrombin deficiency. As Dr. Streif mentioned earlier, one of the highest thrombophilic risks of all the inherited thrombophilias is because of hereditary antithrombin deficiency. It's really the highest as a heterozygous disorder. There have been some quotes on homozygous factor V Leiden being a little bit more prone to having a VTE than hereditary antithrombin deficiency. But remember that antithrombin deficiency doesn't really exist in the homozygous state, especially when we're talking about type 1 deficiency or a quantitative deficiency. That condition is not compatible with life. So folks that we know that have hereditary antithrombin deficiency almost entirely are heterozygotes. If we look at the deficiency of antithrombin and thrombosis risk, if you look at the general population being the index risk, then folks with the prothrombin gene mutation have about a 3-fold increased risk. Factor V Leiden, heterozygosity, 5-fold risk. Protein S deficiency and protein C deficiency, about 10. It's probably 10 to 15-fold. And antithrombin deficiency as a hereditary condition, is about 20-fold increased risk. Very interestingly, and my experience over the last 30 years with individuals with a hereditary antithrombin deficiency really aligns with this slide, the data on this slide. And that is the percentage of patients affected by age 35, 70% of individuals with hereditary antithrombin deficiency will have experienced their first clot. By age 35, that's considered young. By age 50, 85% will have experienced their first clot. And as importantly, recurrence or having a subsequent clot happens in at least 63% of patients. So almost 2/3 of patients will have another clot. And that helps us really decide which patients should stay on long-term anticoagulation, meaning lifelong anticoagulation, even after their first VTE episode. So as you can imagine, there are certain high-risk situations combined with hereditary antithrombin deficiency that really make VTE events more likely in these folks. Surgery, I mentioned pregnancy and childbirth as well. Certainly cancer would be another thing to add on that list as well. And as I mentioned, the recurrence rate of thrombosis is so high in patients with hereditary antithrombin deficiency. And sometimes patients do come to our clinic with known antithrombin deficiency, having had VTE in the past and them not being on anticoagulation. So that presents a particular dilemma about, restarting or reinitiating anticoagulation in someone at a time when they don't really have a clot, but their risk is so high that it really, in most cases, would outweigh the risk of being on the anticoagulant. As I mentioned before, adverse maternal outcomes during pregnancy, childbirth, and the postpartum period. And I showed you some nice data that says that risk goes on for at least 12 weeks in the postpartum period. And of course, there's an increased mortality risk in folks with hereditary antithrombin deficiency. Untreated PEs are associated with mortality in 1 of 3 patients. So there's really a need to recognize that not only is a PE serious and needs to be treated promptly, but in folks with hereditary antithrombin deficiency, their mortality is heightened. It's very true that the initial thrombosis or thrombotic event happens spontaneously, but certainly it could be related to a provoking factor. If I recall the first patient I treated that had hereditary antithrombin deficiency, his first DVT was, relatively speaking, unprovoked. He was playing tennis, did not have an injury, but afterwards, in the hours that came later, had a big swollen leg and was diagnosed with a proximal DVT. So it's hard to, assign whether an activity or an event is provoking or precipitating for the clot, but suffice it to say that many patients report nothing out of the ordinary that preceded them developing DVT. I want to tell you a couple of more important things about the impact of antithrombin deficiency on heparin action. So when the antithrombin concentrations are reduced, the antithrombin is a cofactor for heparin, and that may require increased doses of heparin, right? So a sort of heparin resistance may be occurring when the antithrombin level is decreased because of hereditary deficiency. But the patient's responses may be unpredictable. So I'm often asked, at what level of antithrombin does heparin resistance occur? And my answer is, I'm not sure. I know that the lower the antithrombin activity, the the higher the risk for heparin resistance, but it may be different in every individual. And certainly there are other variables involved in heparin resistance. So that has to really be paid attention to in a very specific way for each patient. We can't really assign a number that says above that number heparin resistance won't occur, below it will occur. That really doesn't hold true, and the real sort of recognition of heparin resistance has to be personalized for each patient. So increasing heparin without considering the possibility of antithrombin deficiency may lead to hemorrhagic or thrombotic complications in the patient. And further, that's alluded to but not written directly on this slide, that if it is recognized that the deficiency of antithrombin is causing some kind of heparin resistance, then supplementing antithrombin may lead to a fairly abrupt change in the sensitivity to heparin. So monitoring the effect of heparin when the antithrombin is being supplemented or manipulated is extremely important, because without that, the patient could be suddenly at an increased risk for bleeding. So ways to recognize hereditary antithrombin deficiency. And here's just a really brief example of a patient who's 48 years of age, and his medical history includes that he had a recurrent DVT. Excuse me. His family history shows no obvious signs of thrombophilia, but there have been unexplained premature deaths on his mother's side. And then subsequently, his daughter has a history of a pulmonary embolism, which occurred during pregnancy. So that type of family history should really put up a red flag that there may be an inherited thrombophilia. Most of the other inherited thrombophilias that Dr. Strife and I mentioned are inherited in a dominant fashion, so they typically don't skip generations. And if the index case has a child, then the child has typically a 50% chance of having the same deficiency or disorder. So always think about inherited thrombophilias, especially if there's this kind of a family history. A little bit about the assays. These are the functional assays based on factor inhibition. So there are a couple of different types, one based on factor 10A inhibition, one on thrombin inhibition. It's very important that you recognize that during a thrombotic event, the antithrombin activity tends to drop, and you may have a spuriously abnormal level at that time. The same is true in the postpartum period, like I showed you in that earlier slide. So your initial testing really should be a few weeks after the thrombotic event. Now, obviously, many of the patients that come to me have their antithrombin measured at the time when the patient is right in front of the doctor who's concerned about this. And we often get low activity levels that on repeat during or after recovery are normal. So that antigen or that activity test has a very high specificity and sensitivity, and it's the first test that we really should be doing. And as I mentioned, the antigenic test just helps us sort out type 1 versus type 2s. Antithrombin deficiency may be acquired, and there's several conditions or circumstances that could lower the antithrombin activity. I mentioned the clot itself in the acute phase can cause a decrease in antithrombin activity, but so can heparin therapy. So during the acute phase of a clot and its treatment with heparin, that's probably the most inopportune time to measure antithrombin activity. Certain chemotherapies like asparaginase can decrease the production of antithrombin and lead to an acquired deficiency. And you can see the rest on the slide here, especially states of consumption can cause antithrombin to be used up and maybe compartmentalized abnormally. Certain situations where antithrombin isn't made properly in disease states And certainly there is increased excretion or secretion of antithrombin in other pathologic states like nephrotic syndrome, inflammatory bowel disease. And we showed in some studies that patients that have chylothorax often will have very low antithrombin activity. So keep that in mind in your postoperative cardiovascular surgery patients. Finally, about replacement, and this is about as much detail during the main talk that I will go into about treatment, but those high-risk situations are when antithrombin should really be replaced. Okay, so as a summary, antithrombin is the most important naturally occurring anticoagulant. It has a role beyond inhibition of thrombin and other serine proteases, and I think we need to understand that better to fully appreciate the role of antithrombin in the body. Antithrombin deficiency in the hereditary sense is an uncommon condition, but the clinical impact may be severe, leading to VTE at a very early age. The patient, the youngest patient I've diagnosed with hereditary deficiency because of an event was 4 weeks old. Antithrombin deficiency should be considered in any patient with unusual clotting or in persons with a strong family history of clotting. And when clinically indicated, antithrombin concentrate is available to replete antithrombin in those deficient patients.